Good morning. I think we're going to go ahead and get started. Well, welcome this morning to our event called Critical Issues of Youth, Current Drug Use Trends and Implications for Today's Youth. On behalf of the Lakeshore Coordinating Council, Network 180, the Kent County Prevention Coalition, the Allegan County Prevention Coalition, and last but not least, Berry County Substance Abuse Task Force, we welcome you today. My name is Stephanie Vanderkoy, and I work for the Lakeshore Coordinating Council as the Prevention Services Coordinator. And today we're really excited because we have about 350 folks that are going to be joining us. So hopefully we will be able to get everybody in here today. I still see a few folks coming in from registration, so we're going to go ahead and let them filter in, and they get to sit right up front. Okay, good stuff, right? Okay, so anyway, I'm going to go ahead and get started with just a little bit about the housekeeping this morning and a little bit about our agenda. And I should have a PowerPoint up here shortly with my housekeeping slides. But anyway, if you didn't figure it out already, when you first walked in, there is some fresh fruit available, so please go ahead and help yourself to that. We also have coffee and other beverages available. Right when you first walked in, right straight there is a lobby, and you can go ahead and purchase coffee. And if you need anything else, like a Diet Coke or something like that caffeinated, you can help yourself to that as well. Today we're going to be having a complimentary boxed lunch, as well as a soda will be provided for you this afternoon at lunchtime. I wanted to mention as well, today's event is being taped. So if you do not want to be taped, you're having a bad hair day, whatever the case is, please let one of us know at the help desk back there, and we can put you in some special seating so that you don't have to be on our camera if that's something that you don't want. All right, the other thing I wanted to mention as well is that resources from today will be posted on our Talk Sooner webpage, which is talksooner.org, as well as the taping for today will be available for you at the Grand Rapids Public Schools website and also on channel 25 for Comcast, AT&T UVerse, Public Access TV, and the Kent County Prevention Coalition website. So I just want to let you know that. A couple other things I wanted to mention as well for those of you who need MCOLS credits, that would be law enforcement. If you need those, don't forget you need to sign in and sign out today. Please do that at our help desk, which was located right across from registration. So please make sure at some point today you do that. Those of you that need the MCBAP credits, you don't have to sign in and out. You will go ahead and get those today at the end of the day after you turn in your evaluation. Those are the only two credits that we'll be offering today. So sorry if I didn't quite get what you need there. So anyway, those are the two that we will have. The other thing I wanted to mention as well, too, is that if you didn't happen to get a sticker when you first walked in, we wanted to make sure that everybody got a sticker so that you could put on our Michigan map where you're from today, because we really want to be able to show Dr. Kevin Sabet, our keynote speaker today, where everybody's coming from and really show him that we have a West Michigan representation today. And last but not least, the facilities, everybody needs to know where restrooms are. So if you haven't already figured that out, walk straight out the door and to your left, okay? That you'll find them right there. So just wanted to make sure everybody knows where those are at as well today. And then on your seat, you should have all had one of these packets. So check your bottoms if you didn't already. Make sure you got one of these, okay, that you're not sitting on it. And inside here, you should have all sorts of goodies. You've got our brochure, a lovely postcard, information about our Talk Sooner app that we'll be going through in just a moment, and information about our keynote speaker as well, Dr. Kevin Sabet. So I just wanted to make sure that you knew that you had that. All right, and just a couple other things for today as well, too. I'm going to go through the agenda. We are going to do a brief introduction this morning on our Talk Sooner media campaign. Myself and Denise Herbert will be doing that here momentarily. Then we're going to have our keynote speaker, Dr. Kevin Sabet, come this morning, and he's going to talk for about an hour and a half this morning, and then we're going to break for a fast and furious lunch. All right, folks? Brace yourselves, because we're only giving you 15 minutes, because this man talks a mile a minute, and we wanted to give him as much time as possible. So what we're going to have you do is at the noon time, I'm going to go up here and I'm going to make the introduction that we have lunch available, and then we're going to just grab our lunches, hit the facilities if we need to, and scoot right on back to our seats and get ready for another hour with our presenter today. Okay, so I just wanted to give you a heads up that get ready for a fast lunch. So that's what we're going to be doing today. Then after lunch, our speaker will be talking just a little bit again about just some other current issues and trends. And then we'll also allow some time for questions, an answer session with him and your evaluation, and we will do our best to ensure that you are out of here at 2 o'clock when we promised. So anyway, that's a little bit about what we've got for today. And I would like to turn it over now to my colleague, Denise Herbert. And Denise works for Network 180, and she's going to go through just a little bit of information for us on our Talk Sooner campaign. So welcome, Denise.
Hello. Good morning, everyone. Man, we're so excited that we have a full room here, a full house. So to get started, as Stephanie said, we'll give you an update on our campaign or some work that we've been doing around the red cup. So when you see this red cup, it's very familiar. And I think all of us, when we see this red cup, how many of us think of alcohol or we think of this as the party cup? You can be honest. Yes. So what we decided to do, as Stephanie said, we're in partnership together. So Network 180, along with the Lakeshore Coordinating Council, along with our area coalitions, we wanted to change the face of this cup. So not just being a party cup. So what we did to change the face of that is to put the number 12 on there. So that number 12 actually represents 4 years ago, we kind of looked at the data, and 4 years ago, the data was telling us that kids are starting to use alcohol at the age of 12. So what we decided to do is to create a campaign around that. So, not just the party cup, but when you see the party cup, now you see the age 12 on there. So it makes you kind of think twice. So 4 years ago, so in 2009, we wanted to help educate West Michigan parents or those caring adults in the community. Okay, I have to keep that in my hand because it has an automatic flow. We wanted to just educate the parents in our community about the importance of substance use or the substance abuse prevention. So again, that's why we created this campaign. With the Talk Sooner initiative, it's about helping the parents, helping the mentors or those caring adults, help them talk to the kids in their lives, the children that they love, and have that information at their fingertips. So what we're doing now is after a 4-year campaign, so starting in 2009, we've been going 4 years strong. So right now what we've done is we've launched an app. So we have a Talk Sooner app that we just launched actually in June. And the part of the reason that we're launching this app is because information now is readily available. So everyone has a smartphone, mostly everyone, has a smartphone, and you want that information at your fingertips. So what we've done in June, we've started this app kind of campaign in the various communities. And over the 4-year process, over that 4-year period, we started with an initial five counties. So what we've done with this campaign, we've enhanced it, we've expanded that, and now we have 6 counties. And actually the 6 counties are listed here. So with the Talk Sooner campaign, when we say that we're going live or we're going mobile and we're introducing this app, you'll see this app in 6 communities. So you'll see billboards, you'll see bus ads, you'll see Johnny ads in the various communities. With this mobile app, like I said, we're trying to place prevention right at the fingertips. So as parents, as mentors, as caring adults, we want to make sure that you have that information readily available at your fingertips. And, okay. We have this on automatic, so, I guess I'm not talking fast enough for the automatic. So we have that at your fingertips. And then actually, okay, bear with me, up at the top there also. With the Talk Sooner, the new app helps remove that awkwardness. So like many adults and many parents, when we have to have that sex talk, how awkward that is. So when we talk about substance abuse prevention, that's also awkward. So with this mobile app, it takes away that awkwardness so you can have that communication or those conversations with your youth. And we say that downloading the app is very easy. My generation, we're called digital migrants. We're not very hands-on with the technology, that type of thing. But what we're saying is downloading the app is very easy. So what you do is go to your app store if you have an Apple. So right now, our initial phase is with the iOS system. So if you have an iPad, iPod, and iPhone, you can go to your app store and do that downloading. And if you're like me, you don't have the iPhone, you still have your smartphone, the Android version of it is coming soon. So we plan on launching that in December. So if you don't have an iPhone, you can still go to the talksooner.org website and get the information at your fingertips as well. What we also say is talk early, talk often. Part of our campaign going through the 6 counties, we wanted to make sure that everyone had a chance to see the impression. And when I say impression, that everyone had a chance to see a billboard, a bus ad, a Johnny ad, etc. And through that campaign, we've had an opportunity to touch 250,000 people. So we know that 250,000 people have seen this app. So what we're trying to do today, why we have this, room full of advocates, I'm going to call you. So as we have the room full of advocates, what we're saying is be responsible and go viral. I know that sounds kind of awkward, but be responsible, go viral, download the app, and tell your friends, your family, and your coworker. Again, that puts that information right there at your fingertips. Okay. Well, it's not advancing. Up at the top, I'm sorry. The last screen that we have actually shows the mobile application, and you have that in your brochure. So in your brochure, you have that picture of what that app looks like. Oh, there we go. So you have a picture of what the app looks like, and it's broken down into several different categories to kind of help you retrieve the information that you need. And what we say is, you know what, go mobile. Go mobile with this app. Go mobile with the power of prevention today. And download our app. It's easy and very accessible. So what we'll do right now is we'll have Stephanie rejoin the stage, and Stephanie will walk through the many different categories of that application. It's not working.
Oh, I know it. All right, well, good morning once again. And what I wanted to do was spend a couple minutes talking about the app this morning, and I had great intentions of having my smartphone plugged in. And when I got here, it didn't work. So I apologize that I do not have my phone to be able to show you, but I think up here you get a pretty good idea of what our app looks like. For those of you that maybe don't have a smartphone, one of the things I just wanted to mention is that at the bottom of the smartphone, there's always kind of your key or your home page, if you will, that has the different topics. And what we have listed is talk, which is the first button that a person can push, and that's where, for a parent, this is how do you talk to your kids? What do I say? When do I say it? That information is listed for you there on the app. The second part that we have is the learn. So as a parent, I don't know anything about current drug use. What's happening? Is it still alcohol? Is it marijuana? What's this drug Molly I keep hearing about? What on earth is any of that stuff? That information is also listed in there for you as a parent under the learn, so you can scroll and learn more information about it. The Go tab is a tab where if I've determined, okay, I think we've got a problem going on in my house, maybe my son or daughter, niece, nephew, that type of thing, maybe is dabbling with drugs, now what? What do I do? There's a lot of help available for folks, and so we list it there for people by county. We list phone numbers. We have national resources as well, so just in case if you download this app and you're not from around the West Michigan area, you can still find the information for treatment in your local community. Then the other part of the tab we have is watch. This is learning about warning signs with your son or daughter. So knowing who their friends are, we list information there on that. We also list information as well as what it might look like if a person might be high. I know that sounds really strange, but as a parent, they might not have a clue what they're looking for. So we list really basic information on there for them. And then the last tab is the More tab. This is where we have frequently asked questions. We also have information on there about our local coalitions. So if a person is really motivated and they would like to get involved in the Berry County Task Force, that information is listed on there for them. So in a nutshell, that's basically what we have on our app, and we consistently keep adding more and more information. So it's an app that we keep very live. We're constantly adding more content on there. So anyway, I just wanted to let you know that and ask if you would to go ahead and download that today if you can. And at this time, I'm going to turn it over to my friend and colleague, Liz Lentz, who works for the Berry County Community Mental Health, and she is going to be going through a couple of things for us, which is called the Poll Everywhere. We're going to be doing a little surveying here of all of you, and Liz is going to explain why, how we're going to do that, and then we'll go ahead and get on with our presentation here in just a moment. So welcome, Liz.
Thank you.
Yep.
Good morning. What's the problem with the front seats? Nobody wants to be that close? It always happens everywhere. Well, good morning, and thank you all for coming this morning. We are very excited to bring today to you, and I know Stephanie probably talked about that this has been a regional partnership between many entities, so we're thrilled to actually see today happen. We are going to, I'm going to invite you to participate in a poll, and as soon as Kyle can bring up our screen, this is an opportunity for you to actually use your technology during our presentation. I'm sure Stephanie talked about turning it to silent mode or vibrate, but if you do have your cell phone with you and you have text capabilities, we're going to take a brief poll, and we're going to start with a practice question in a minute. Thanks for bearing with us. I feel like I should have a stand-up routine or something, and it's just, I'm a little bit dull this morning. Usually I come up with about 29 things, but should we move on, Heidi? Oh, here it is. Okay, very good. How many of you have ever used Poll Everywhere before? Raise your hand. All right, great, some of you. We have an opportunity today for the first 250 respondents who can text using their phone to help us with this. So if you have used this before, simply take out your phone, and in the text line who you're going to text this message to is the number 22333. Some of you are already ahead of the game. And you can see that this question says, I would describe myself as a morning person, a late night wonder, or an anytime person with the help of major amounts of caffeine. So please take a minute to text your answer to 22333. 4 of you so far. Let's see where we're at. And by the way, we are going to ask some pretty important questions that kind of give us an idea of what you folks already know. And so this is kind of a modern way of doing a pre-test. And we won't have a post-test. So thank you for participating with us today. All right, we'll give you another second to finish this one up. So far it looks like we're a pretty caffeinated bunch. Caffeine is still a safe drug to talk about, I think, but, late night wonders are catching up. Took you a little longer, yeah. You need to be up here with me, okay. All right, so has everybody done polling? It looks like the clear winners are the people who are here today with the assistance of their caffeinated beverage. So we're gonna go ahead and go to the next poll, please. And this question's going to come up, and it says, the #1 drug problem in West Michigan is, your first choice is marijuana, painkillers, methamphetamine, alcohol, heroin, or tobacco. No giving away the answers. You guys are good. All right, so we're slowing down a little bit. Looks like the clear winner in this case is alcohol, and that's correct. Alcohol tends to be the number one, and it is the number one treatment admission for all of our counties and regions, closely followed by marijuana. Painkillers or prescription medications usually come in third. And fourth place usually flip-flops, but could be a tie between methamphetamine and heroin based on some local data. So let's take a look at the next poll. Get your phones ready. According to 2012 MiFi results, Michigan youth generally believe tobacco use is more harmful than marijuana use. True, false, or I'm not sure. And the MiFi is the survey that's given to 7th, 9th, and 11th graders pretty much across the state. Great, you guys know your stuff. This is quite a shock to us, as you all can believe, that marijuana is considered safer and less risky than tobacco. And this is something that we in the prevention field really feel strongly about addressing. So let's take a look at the next poll. Bath salts are illegal nationwide. True? False? I don't know? Or why would Calgon be illegal? just to see who goes for that answer. There's one in every crowd. Maybe today we have more than one. Last year, 2012, there was federal legislation passed banning the production of synthetic drugs such as bath salts or K2 spice. However, as you know, these chemicals, new chemicals crop up all the time. So we are operating under the impression that the answer is true, although with the market, they're one step ahead and there are new products coming online all the time. And I'm sure Dr. Sabet will speak about that. We're going to take a time for one more question. So we'll go to the next poll. According to SAMHSA, which is the Substance Abuse and Mental Health Services Administration, people who use prescription painkillers non-medically are 19 times more likely to initiate heroin use. True or false? We lost our numbers, but it looks like most everybody knows the answer to that one. And it is true. And that was just released this summer by SAMHSA. So ladies and gentlemen, thank you for participating in our rapid response poll. We'll have 2 more questions during the lunch period. And I'm going to switch gears here just for a second, and I'm going to introduce our speaker. We are truly lucky to have, and you're going to understand in just a few minutes why we are so truly lucky to have Dr. Kevin Sabet with us today. I'm going to read his biography and then we'll welcome him. This is what you came to hear, and we think at the end of the day you're going to appreciate his message. Dubbed the quarterback of the new anti-drug movement by Salon magazine, Kevin Sabet, PhD, has over 18 years of experience working on drug policy. Dr. Sabet is the director of the Drug Policy Institute at the University of Florida and an assistant professor in the College of Medicine, Department of Psychiatry. Along with Patrick J. Kennedy, he is the co-founder of Project SAM, Smart Approaches to Marijuana. He is also a policy consultant to numerous domestic and international organizations through his company, the Policy Solutions Lab. His current clients include the United Nations, where he holds a senior advisor position at the Italy-based United Nations Interregional Crime and Justice Research Institute. That's going to be one of the questions at lunch, okay? I'm just telling you. And other governmental and non-governmental organizations. He also recently served as the only non-medical doctor on the writing committee establishing the official position on marijuana legalization for the American Society of Addiction Medicine. From 2009 to 2011, he served in the Obama administration as the senior advisor to Director Kulikowski at the White House Office of National Drug Control Policy. Representing his nonpartisan commitment to drug policy, he previously worked on research, policy, and speechwriting at ONDCP in 2000, and from 2003 and 2004 in the Clinton and Bush administrations, respectively. He remains the only staff member at ONDCP to hold a political appointment in both the Bush and Obama administrations. Dr. Sabet is also a staff columnist at thefix.com and a regular contributor to opinion editorial pages worldwide, including the Washington Post, the Huffington Post, New York Times, Vancouver Sun, San Francisco Chronicle, Seattle Times, CNN, CNBC, and many more other media outlets. His first editorial since leaving ONDCP, published in the Los Angeles Times in September of 2011, earned him a 5 Best Columns distinction by The Atlantic. In his most recent senior position at ONDCP, Dr. Sabet advised Director Kurlikowski on all matters affecting priorities, policies, and programs of the National Drug Control Strategy. He was one of 3 main writers of President Obama's first National Drug Control Strategy, and his portfolio included leading the office's efforts on marijuana policy, legalization issues, international demand reduction, drug driving, and synthetic drug policy. He represented ONDCP in numerous meetings and conferences and played a key role in the administration's international drug legislative and diplomatic efforts at the United Nations. He has published widely in peer-reviewed journals and books on the topics of drug policy, cocaine sentencing, legalization, marijuana decriminalization, medical marijuana, addiction treatment, drug prevention, crime, law enforcement, and other issues. Since consulting in the fall of 2011, he has been quoted in over 15,000 news stories related to drug policy. As a Marshall Scholar, he received his PhD and MS in social policy at Oxford University and his bachelor's in political science from the University of California, Berkeley. He currently lives in Cambridge, Massachusetts with his wife, who is a PhD candidate at Harvard University. So would you please join me in welcoming Dr. Kevin Sabet to West Michigan.
Great. All right, good morning, everybody. Can you hear me? All right, well, it's great. It's really wonderful to be with you. First, I want to thank Liz and the whole team for being in front of you. She shared with me some of your backgrounds and coming from law enforcement, prevention, treatment, recovery. It's really, you're the ones every day who deal with this issue, the people on the ground, where us policymakers kind of look at it from 30,000 feet. So I have tremendous respect for the work that you're doing on a day-to-day basis. I feel extremely lucky to be here today because there was something that was going to be preventing me from getting here, and it was called an airplane. When Liz and I have been planning this for over 8 months, I mean a very, very long time at this point, and she said that you probably want to get here the night before. It's going to be easier. And I said, I'm traveling a lot. I'd really just like to come the day of. It's really no problem. I fly over 200,000 miles a year, and I really have been very lucky. Well, this morning, 4:30 a.m., get to the airport for my 5:30 flight to Cleveland, connecting here. And 5 minutes before we're about to have our on-time departure, the crew decided not to show up. And actually, one crew member left, which was interesting. And so the whole flight was canceled. And to make a very, very long story short, because I don't want to cut into what we're getting at, by some miracle, we found another flight, 2 flights in a row that, because the first flight was 30 minutes early and the connecting flight was 30 minutes late, I was able to get the last seat on each of those 2 flights. So thank you for having me here today, and it feels really good to be in Grand Rapids today. Much better than I even had thought originally, so thank you. So I'm going to talk about, this is kind of a semester's worth of information that we're going to try and whittle down to 2 hours, 2.5 to 3 hours, including questions. So if I go very quickly, I apologize for that in advance. And you do have the PowerPoint in front of you. This one is a slightly modified version on the bits about marijuana, but the content is almost the same. And I really hope we will get a chance for some Q&A, because I think that is when we can bring out a lot of the more interesting issues. So today I'm going to talk about prescription drug abuse first, touch a little bit on synthetics, look at the other drugs with regards to methamphetamine, heroin, cocaine, and then I'm going to end, and actually the vast majority of the presentation is going to be on marijuana, because that's where my recent research has been, and that really is where the discussion of this issue is right now, for better or worse. I mean, when this issue is even covered in the media anymore, when the drug issue is covered, it's usually talking about marijuana now with the rapidly changing laws and regulations. So I'm going to talk about that. Let's first, though, begin with arguably the largest drug problem that we have in terms of death, certainly the largest source of accidental death now in this country, and that's prescription drug abuse. And many of you in this audience know what we're talking about when we say prescription drugs, but just to go over a little bit, depressants, opioids, and morphine derivatives, by the way, that includes methadone, stimulants, antidepressants, etc. These are the brands. You've seen the commercials for many of them actually over and over. The U.S. is one of 2 countries in the world that still violates international law in the case of advertising for prescription drugs. So that's why when you go visit Europe or go to South America, you don't notice every other commercial being about a prescription drug, because no other country really does it other than us and New Zealand. And the result of sort of, I think, this culture of prescription drugs, and really this idea that prescription drugs, because they're medicine, and let's not forget, they are lifesavers for hundreds of thousands of people, they can obviously also be abused. And so some of our best statistics show that every day, roughly 2,500 kids, youth aged 12 to 17, abuse a prescription pill for the first time. The average age around 13 or 14, and a study last year, the Monitoring the Future, basically found that almost 2% of 12 and 13-year-olds and 2.5% of 14 and 15-year-olds abused a prescription drug in the past month. Over half of kids think that prescription drugs are much, much safer than any drug that they can find at the street. That translates to about 2.5 million teenagers, and it really we're focusing on drugs like OxyContin when it comes to kids. And as we kind of, as Liz alluded to earlier in your survey, teens that abuse these drugs are much, much more likely to use other drugs like marijuana, heroin, cocaine, etc. The last year, which we have data, 2008, we know that there are about 600,000 emergency room admissions for prescription drugs alone. And it now constitutes the largest cause of percentage of deaths from drug overdose, and actually now the largest cause of accidental death in this country are poisonings related to prescription drugs. In terms of what we're actually looking at, it said hydrocodone, oxycodone, and then the rest are sort of below that, but really looking at hydrocodone. I think an interesting statistic is to look and see, well, where are people actually getting it? Because does it follow the other drugs in terms of cocaine and heroin on the black market, or how is this happening? And interestingly enough, the vast majority of kids get these drugs free from a friend or a relative. There's not actually money exchanged. Then the second is bought and took from a relative, and then third is from one doctor who overprescribes. And of those people who got it from a friend or relative, they got it from one doctor. So this is really isolated to really a small number of people. The nexus is very small that causes this big problem. Something that was very shocking to us when I had left the Bush administration in 2003 and came into the Obama administration in 2009. In between that time, one of the statistics, and there were a few I'll go over today, but certainly one of the top ones that shocked me when I looked again at the stats was that when we looked at emergency room admissions, the numbers for the misuse or abuse of pharmaceuticals overtook those for illicit drugs. So there were more people going to the ER for prescription painkillers than for marijuana, heroin, or cocaine or methamphetamine by raw numbers. That's a pretty shocking statistic. Then when you look at who's actually addicted, again, we saw this huge rise in the number of people that were classified as with abuse or dependence. And again, we really see that this is focusing here on oxycodone in terms of the percent increase in admissions. Again, treatment admissions for all opioid analgesics just rising dramatically. And then the other statistic that shocked us was, and we don't have great stats in this country for deaths because it's very difficult to collect that data. There's a couple of years lag time, but some of the more recent data that we're able to get basically shows that around 2005, drug-related deaths overtook firearm injuries, and no one thought it would ever reach up here, the top of motor vehicle accidents, But actually, according to the data, when it's put together for 2009 and 2010, it does show that drug poisonings now have exceeded not only deaths by firearms injuries, but also suicide, homicide, and the top category, which is accidents and car crashes, which was also very, very surprising for us. In many states, this was already happening, where, in fact, here in Michigan, where there were more drug-induced deaths than motor vehicle accidents as early as 2007. What's interesting about the death statistics with prescription drugs is that it totally dwarfs the height of the cocaine epidemic in the 1980s, driven mainly by crack cocaine, and the height of the heroin epidemic, the last time we had a heroin epidemic in this country, which was really the mid to late 1970s. The number of deaths from prescription drugs here in this box, it just totally dwarfs the number for cocaine or heroin. So it's a magnitude larger in terms of the kind of consequences that we're dealing with. And it's not only death that we're concerned with, and then you all know it's not only addiction that we're concerned with either. There's plenty of negative things that happen when somebody uses occasionally or moves on towards dependence. For every one overdose death in 2007, we calculated 7 people went to treatment for it. 29 people went to the ER, 148 people could be classified as being abusive or dependent, and 450 were essentially using it non-medically on the road to abuse and dependence or addiction. And so it's not only deaths that we need to be concerned with when it comes to prescription drugs. And it costs us a lot of money in this country to deal with. Over $55 billion every year this country loses as a result of prescription drug abuse, half of which come from direct healthcare costs, but the other half that come from things like tardiness at work, things like car crashes and accidents, child neglect, etc. In fact, opioid abusers are cost 9 times more than the average healthcare consumer in this country. So we knew that one of the first things we had to do was coordinate a federal response to this issue. And so there was actually 4 focus areas that we sort of honed in on in this prescription drug plan, which is still really the policy of the land that we're concerned with. The first is education. I'll go into each of them. Then prescription drug monitoring programs. Third, proper medication disposal. And fourth, enforcement. So first, it was important that we not only educated young people so that they knew that just because this drug was in a pill and prescribed by a legitimate doctor, it could be dangerous, but also parents and other patients. So, that's a huge part of this is what you're all doing in the community with community anti-drug coalitions, talking about how to store and use these medicines properly, working with pharmacies to make sure that it doesn't get into the wrong hands, but also physicians. We found a huge education gap, and pretty ironic when you think of, folks always want to treat addiction like a health issue, and I agree we should. However, we sort of say that, but only half of our residency programs get even 3 to 12 hours related to anything regarding addiction. So we say we want to treat this like a health issue, but our doctors actually are not trained up properly in this issue at all. There has been a follow-up since that 2000 study showing things have improved, but not to the extent that we want. Even pharmacists who, these are the folks that are dispensing these medications. 2/3 report receiving 2 hours or less of addiction or substance abuse education in pharmacy school. And that's for all addiction. It's not just for how to handle opioids. A third of folks in pharmacy, a third of pharmacists reported no training at all. So we really did want to increase the number of pharmacists getting addiction-specific education. The next thing we focused on were prescription monitoring programs. Have most people heard of prescription monitoring programs before? Essentially a computerized system to make sure that folks aren't going around doctor shopping, so that when you enter their unique ID identifier, it would come up whether that person has already been dispensed enough medications. Most states have it. These 2 states are working on it. But essentially, some of the challenges, though, we had were states sharing this information. Okay, a lot of states didn't want to share that information. And the other thing we're trying to do is link it with state health information exchanges as the Affordable Care Act comes into play. We really need to work with ER departments and others. There's still a lot of work to do on this to make sure that these prescription drug monitoring programs aren't just a huge database with nobody actually utilizing them or accessing them. The next part of this was proper medication disposal, because even if you asked the FDA as early as 2006 or 7, what do I do with my medications? You got a lot of strange or murky answers. It was like, well, mix them with coffee grounds or kitty litter if you happen to have them, and then dispose of them. Flush them down the toilet was another piece of advice, which now we know can really hurt the water supply. And there are a lot of genuine people that have a lot of old medications. I mean, when I, busted my shoulder and had to get, my shoulder was dislocated in 2003, the doctor gave me about 80 OxyContins. And I was left with 79 of them. And I still, to be honest, I think they're still in my medication. I mean, I didn't even know what to do with it by 2006 when we were actually asking for guidance here. So we're trying to work with, DEA now has regular take-back days. Have you all participated in that locally? Yeah, I see a lot of nodding heads. But we really need to actually have this sped up so that there's a proper place in the community. Some communities have permanent drop boxes. I don't know if you all do. Some of you were saying you do. That's good. But not all communities have them. And then, of course, enforcement, which really has to be part of this as well. Closing down the pill mills in Florida, closing down the pill mills in the South that would bring a lot of folks from the Northeast corridor down in buses. You've all heard about this, busing people down to just go to these really rogue pain clinics with folks that were just only there to get high. So we worked on that with state leaders. So really, I think the issue of prescription drug abuse is a critical time for the marriage of public health and public safety. It's not one or the other. We need to have the right balance of strategies. I think there has been a turnaround recently with prescription drug abuse. I wouldn't celebrate yet because, as we're seeing some recent reductions in prescription drug abuse among kids, we're seeing some increases in heroin in some communities. I don't know, have you all also seen that here? Again, I see a lot of nodding heads. So we really need to make sure we're not pushing down on one and popping up on the other. But I think from a policy perspective, an interesting question to ask is, what can the prescription drug problem teach us about illicit drug use? Let's think about prescription drugs for a second. They are highly controlled, right? They're legalized. They're regulated and controlled very, very, very tightly. You have to have $1 million plus education to be able to write a prescription. So that sounds pretty tightly controlled to me. They're available and abused at extremely high rates. They have medical properties, we know that, but they also cost billions in social costs. So I think when we think about what to do with some of our other illicit drugs, we shouldn't forget our experience with a legal drug like prescription drugs, which have caused a lot of problems. I'm going to go forward here. Let's start first on alcohol, which you all identified, I think rightly so, as the #1 problem among youth. Clearly, the greatest concern here are binge drinkers. Just like many other substances, we know with alcohol, it's the 20% of users, and I'm going to come back to this later when we talk about marijuana. It's the 20% of users that consume about 80 to 85% of the volume of alcohol. Okay, so most users drink responsibly. But that 20% is what causes a vast, vast majority of the harm and the problems. So that's why focusing on binge drinking is really important. The good news is, in this country, binge drinking and drinking also among young people under 21, we have reached historic lows. Actually, it's been going down in the last few years. There's been a lot of social host ordinances and local community issues that have been happening. Public service campaigns. Tobacco, another great example of public health coming and really creating a taboo around tobacco. I don't know one kid, not that I know what's cool anymore, but I don't know one kid that I talk to who says that smoking cigarettes is cool anymore. There has been a total social shift in the last 15 years, which really we need to thank everybody in this audience for doing that. And we're reaching historic lows for tobacco. Now that's plateauing a little bit. It's not going down as much as it has been, but kids are perceiving the risk of tobacco to be very high. We used to have about 500,000 tobacco deaths a year. Well, we're closer to 400,000 now, so there is some progress being made there. And then when we move from tobacco on to synthetic marijuana and synthetic drugs, so first I'll talk about synthetic marijuana, that really presents a unique challenge. As Liz mentioned, there is some national legislation, but the issue, of course, as you all know, is that change one molecule here and there, and then you've changed the characteristic of the drug. So the federal legislation, actually, the intent is to allow DEA to much more rapidly schedule these drugs, and also what I was pushing for was I think it's still going through the system, is allowing for a more generic law, which would sort of be a catch-all, because once you start defining all these drugs, it will be, clearly there will be the loopholes used by producers. It's marketed, obviously as a legal high, as herbal incense. There have been thousands of emergency room admissions for kids on this. We only started asking kids about this in 2011 with the Monitoring the Future study, but in that year, 11.4% of 12th graders, or 1 in 9, reported using the substance in the past year. So that's pretty common. I mean, given the number of total drugs that are used. If you look at poison control, they have been rising, the number of calls to poison control centers for these substances, the health warnings, all of these things. So we really, we need local community coalitions and others to keep and treatment centers also to report the effects, local community coalitions to work with your elected officials to make sure you have more of a catch-all legislation as opposed to the legislation that only targets single substances. Cocaine is really interesting because essentially we are living through a historic low, historic in the last 30 years, I should say, of cocaine use in this country. And it's really something that we don't hear about. I mean, how many people here know that cocaine use in America has dropped 60% in the last 15 years? Okay. This is the untold good story. We hear all the bad stories. It's important to give law enforcement and, frankly, supply reduction efforts of crop eradication and alternative development in Latin America, some do, and some for the positive outcomes that we've had. So we actually have had really declining cocaine use, especially among kids, reaching, that's annual prevalence 2%, 2.5% among 12th graders. Heroin, again, in the 70s we saw, of course, the epidemic we talked about. In the early 90s we saw an increase in heroin. That was dropping off actually very nicely since the mid to late 90s, basically until the mid to late 2000s when we saw this change from prescription drugs to heroin. Now, still the number of kids using heroin is minuscule. But I think we need to watch the increasing trend. I mean, it's sort of going from 0.1 to 0.2% of high school students who report. So we need to watch it. I think we need to watch it in regional areas. Barry McCaffrey once said very wisely that, we don't have a national drug problem in this country. We have local drug epidemics. And I think that's very true. You have local problems as opposed to one national problem. We have seen some progress made with methamphetamine. You always have to watch that because the numbers sort of go up and down very, very quickly. But from that height that we were seeing in the late 90s and early 2000s, especially among kids, but also among all users 12 and older, even in the last 2 or 3 years, we've seen about 100,000 fewer users of methamphetamine. When we look at this graph here, this is a steady decline since 2002 of past year methamphetamine first-time users. So last year, 133,000 Americans used meth for the first time. That's comparing to more than double that 10 years ago. So I think that's another good story, but we have to obviously monitor that since we actually had a very historic decline in 2008 and it's been rising since then. So depending on where you look at. Now, let's get to I think, one of the subject that's going to consume most of our time, and I have to do my book plug here because I lugged all of these things on both planes, but I only brought a few. There's about 20 or so we'll be selling, but basically the rest of the program is going to focus on the research I did for my book here, which is called Reefer Sanity, 7 Great Myths About Marijuana, and you can also buy it online. I want to go through each myth one by one because they are lengthy, but first, let's just look at the number of users of marijuana in this country. Essentially, we're about 7% of Americans that use marijuana that admit to using it regularly, at least once in the last 30 years. There had been a pretty nice decline in fact, this is better. This is among kids. There had been a pretty nice decline from the late 90s, early 2000s, up until about 2007, when we really saw a very steep increase again that was very disturbing. Here it started among 10th graders, Here it started among 12th graders. Maybe I should do this. And recently we've kind of seen a little bit of a dip or a steady. What's interesting with these statistics is it's good to sort of go a little bit deeper than the press releases. The National Survey on Drug Use and Health just came out. This is the Monitoring the Future study, which is the University of Michigan study. But the National Survey on Drug Use of Health that came out 2 weeks ago essentially found no increase in the last 3 years among 12 to 17-year-olds for marijuana use, which is good news. However, when you delved a little deeper, you saw that was no increase among boys and about a 25% increase among adolescent girls. The sheer numbers and the statistics masked the fact that there was that increase among girls. So that it's important to look at those gender differences. What we know, really, if there's one truism here in prevention and in the work we do, it's that the past year use of marijuana almost directly mirrors the perception of risk. And that's what all of you work towards, increasing the perception of risk of any drug in order to lower that use. And this was sort of the late 2000s here, as perceived risk for marijuana declined very sharply, then all of a sudden the use of it went up. I think it's important, and sorry for the red here, but I think it's important to look at, though, let's compare marijuana with our legal drugs. It's important when we talk about policy solutions, what those are. Well, we know that over 52% of Americans regularly drink. Now, those are adults 12 and over. 27% use tobacco products, the vast majority being cigarettes. That's still 1 in 4 Americans that use tobacco. And marijuana is about, like I said, 7.3%. Again, very interesting to look at legal versus illegal in terms of who's using. And it's important when we start looking at these myths. So let's start debunking these myths together. The first, myth 1, marijuana is harmless and non-addictive. Well, we know that that's obviously not true. The best science that we have, and this is not science that's that there's a controversy around. A lot of times you'll hear, well, this study says that, and that study says that, and this scientist says this, and that scientist says that. The only folks I see denying the fact that marijuana is addictive are habitual marijuana smokers and the marijuana legalization lobby. Right, not the American Medical Association, the Psychiatric Society, on and on and on. Those physicians, National Institutes of Health, they will readily acknowledge that marijuana can be addictive. And what's interesting is that, we know that the adolescent brain, you all know, is forming and priming really until age 25. It's figuring out who it's going to be for its whole life. So it's why, you learn a language when you're 3 or 4 versus when you're 30 or 40. Right? It's a lot easier to learn when you're younger. Your brain is figuring out who it is. You have a chance to catch that. Swimming, right? You want to learn swimming as young as you can versus when you're in your 40s or 50s. It's a lot harder to learn to swim, and learning how to drive, it on and on and on. So we know that for all drugs, it's the same effect in terms of like those activities. In other words, the brain might pick it up, and there you're going to have an addiction, or it may not. But if you introduce it to the adolescent brain versus the adult brain, the adolescent brain is much more likely than the adult brain to pick it up. And it's the same thing with those activities I mentioned. So marijuana is no exception. We know that when you start marijuana when you're 13, actually your chances are 1 in 4 of becoming addicted. When you start when you're 16 or 17, your chances get a little bit better. You've delayed that use. It's 1 in 6 become addicted. And remember, we're only looking at addiction, right? The end of the spectrum here. We're not even looking at problematic use and dependence. We're looking at addiction. And we know that if you try marijuana as an adult after age 25, your chances are about 1 in 10 or 1 in 11 of becoming addicted, right? So the older you get, the more apt you are to addiction. What I think is really interesting, because the first question I get after that usually is, well, great, but it's not as addictive as alcohol or heroin or anything else. And it's interesting to look at the addictive chances that you have when you start drug use as an adolescent. So when you start as an adolescent, a 15, 16, 17-year-old, tobacco, cocaine, and heroin are virtually roughly the same addiction chances. About 1 in 4 chances at that age, at 16 or 17, you'll become addicted after the first time you try this drug. This is what this means when I say chance of addiction. I mean after one use. And with alcohol and marijuana, it's very similar, actually. Stimulants, alcohol, and marijuana hover around 15 to 17%. So obviously, when I hear a question like the one earlier, that kids are asked, are cigarettes more harmful than marijuana, or you hear this all the time, alcohol is not as harmful as marijuana. Well, it just depends on the outcome that you're looking at. right? So if you're looking at addiction, that's true. Tobacco is more harmful than, frankly, and when you look at adulthood, tobacco is more harmful than heroin when it comes to addiction. When you're an adolescent, it's about the same. But we can safely say tobacco is more harmful than marijuana when it comes to addiction. Okay, that's fine. However, what about when it comes to something like crashing your car? Right? Well, to tobacco, there's a 0% chance of tobacco intoxication related to motor skill impairment, right? Tobacco is not intoxicating, marijuana is. So marijuana would be more harmful on that respect. Okay, well, what about lung cancer? Well, I'm going to get to that later. Lung cancer is more connected with tobacco smoke than it is with marijuana. Okay, well, what about dropping out of school? Marijuana definitely takes the cake there between marijuana and tobacco. So again, my point in saying these things is that when somebody says to you, well, this is more harmful than that's more harmful than this, we need to, more harmful for what and compared to what are important questions that you have to ask. When we look at those who are dependent actually using and going to treatment, marijuana beats them all in terms of the number of people 12 and older who are in treatment today for their primary condition, reported by themselves to their caseworker. Marijuana the most, followed by pain relievers, cocaine, there's heroin over there. And one of the reasons why we're seeing this huge increase in treatment admissions, and I actually skipped through this chart because it's so small, but essentially, in the last, between 93 and 2008, I mean, the number of marijuana treatment admissions have skyrocketed. So why is that? 1993 is not that long ago. And I would posit to you that the reason is because the marijuana of today is not the marijuana of yesterday. Essentially, we're looking at a whole totally different drug and makeup of that drug. Producers have learned through wonderful botanical techniques to essentially manipulate the marijuana plant. Remember, marijuana has over 500 components in it. When you smoke it, it has thousands, but when you heat it. But when just the marijuana plant itself has 500 components about. One of those components is the one that gets you high, and that's called THC. So what producers have been able to do is essentially manipulate that THC level so high now that we're starting at 1% in 1960, which I like to say is sort of like, if you smoked the hemp waffle cardboard box that you get from Whole Foods. That would be about what you would get from 1960. But now we're at 14%, average, by the way. If you're going to California and talking to a lot of folks and kids who are savvy about getting their marijuana and you present 14% marijuana in front of them, they'll laugh at you. But this is average of the seizures all around this country. But what's really interesting and rarely talked about are the other ingredients in marijuana that not only don't get you high, they actually remove the high. They take the high away when combined with THC. One of those things is called CBD. Well, no one ever had really looked at CBD in terms of, well, where is CBD in marijuana? So I said, well, we know where the THC is, let's look at the CBD. Well, when we looked at the CBD, we basically found that it has been steady and declining between 0.3, now about 0.2, 0.1% in smoked marijuana. Virtually non-existent. Just enough in there because it's part of the genetic makeup of the plant. But other than that, it's not in there at all. So we've seen the CBD go way down, the THC go way up. That obviously creates something that's much more potent. And it's the reason why we've gone from 16,000 emergency room admissions in 1991 for folks with a marijuana acute episode to almost 400,000. And 2008 is the last year with which we have data. Remember, that's when marijuana use was at a 10-year low. So imagine what it is now when marijuana use has gotten so much higher among the general population. But conservatively, we can say 400,000 ER. And people say, well, how would you go to the ER for marijuana? It doesn't kill you, right? And who's heard that, right? Marijuana doesn't kill. Saying marijuana doesn't kill is exactly like saying cigarettes don't kill. And I'll tell you why. Because you cannot sit, when you say marijuana doesn't kill because it doesn't produce overdose, it's not like heroin or cocaine. Well, that's true. You're in one sitting, it's very, very, very difficult to actually have a fatal overdose as a result of marijuana. Well, what about tobacco? That's the exact same thing. There is no such thing as tobacco overdose. You can smoke, I wouldn't advise it, but dozens of cartons in one sitting. There'll be a lot of bad things that happen to you. But death actually there has not been a recorded death for that. And the same thing is with marijuana. You can sit down and smoke, as much as you want. A lot of negative things will be happening to your heart, to your lungs, to your brain, to the way you think, your cognitive development, etc. but you won't have that fatal overdose. So these are all these catch-all phrases that the marijuana lobby has used very, very effectively to change the attitudes about marijuana in this country. What's so ironic about that is that when you speak to the public health professionals, folks like you, but also physicians who deal with addiction every day, and scientists who look at this in a laboratory and look at this in social science and experiments, they have been documenting, many more problems over the last 30 years for marijuana. I'm going through some of them today. So at the time when they're documenting all of those problems going up, the ER admissions, the treatment admissions, kids use, all this stuff, we have had this growth in misunderstanding that marijuana is harmless, relatively harmless, not as bad as alcohol. What's the big deal? We should just treat it like alcohol and legalize it. It's a total incongruency to public health. And I would argue the last time we had that incongruency to public health was with tobacco in the 1950s. And I'm going to make some of those parallels a little later. But back to the slide. So, 400,000 emergency room admissions, usually due to things like acute panic attacks. And, you talk to an experienced marijuana user, the guys that like to, comment on my articles online. And they, they'll say, well, I smoke every day, and not only am I not addicted, because I just smoke every day, I'm not addicted. Not only that, what are you talking emergency room poisoning? What are you saying? I've never been in the emergency room. Well, yeah, okay, for that experienced marijuana user who's been smoking for 30 years, increasing that dosage and increasing that THC and building up your tolerance, yeah, maybe for you, when you ingest a marijuana brownie with 20% THC, it's not gonna be a problem. But if you're a kid or even a naive user adult who hasn't used in 20 years, and I've actually talked to a lot of parents that last used in the 60s and 70s and now sort of tried it recently because it's kind of like everybody's doing it and now it's like at parties, and they have gone to the emergency room for THC because of the acute anxiety and panic attacks as a result. In my book, I talk about a very interesting guy who actually was the PR director for the Texas NORML chapter in 1973. NORML is the National Organization for the Reform of Marijuana Laws. Experienced marijuana user, admittedly. And throughout the 1960s and 70s, he hadn't touched marijuana like many Americans for 25 years. He lives in Northern California. His friend a couple years ago said, come on, you got to come to this medical dispensary. I'll get, just try it again. I'll give you a brownie. It's, how bad can that be? It'll be chocolatey, it'll be fine. Well, he ingested the brownie, and he had a hallucinogenic trip, which he reports in my book, I take it verbatim, that if you didn't know what drug was involved, you would definitely think it was LSD or ecstasy. I mean, he got so paranoid as a result of that ingestion of that THC in that brownie that's so concentrated there in the brownie, that it completely frightened him. I mean, he was having effects for days. And so, yeah, for a lot of folks, yeah, that's not the majority of people who try marijuana every year. I will admit that. But that's also not a tiny number that we can just cast off as not having a health problem. We know the exact parts of the brain, too, that marijuana touches on. Things like memory, learning attention, and reaction time. I'll talk about driving in a minute, but it's, the reaction time is a huge thing when it comes to things like manufacturing at a job at your employer, but also on driving. And so I'll talk to kids all the time that say, okay, come on, Kevin, when I'm drunk, or my friends are drunk, they're, driving, it's horrible, they're going like 160 mile per hour, it's so deadly and dangerous. When I'm on marijuana, I'm just going like, I'm going like 30 in a 65. Okay, well, I mean, just choose which one you want to do. They're both dangerous. I mean, this is the whole point, right, with looking at the flaws of looking at like alcohol versus marijuana and comparing it like that. Yeah, they are different. Alcohol certainly more violence-inducing than marijuana, no doubt about it. But it doesn't hurt your lungs and stunt your IQ and your actually development at school as much as a drug like marijuana. They're very, very, very different. One area where they're extremely different, actually, alcohol and tobacco versus marijuana, and even cocaine, heroin versus marijuana, is the connection with mental illness. We now know the very, very close association. Nothing in science is a causation. If I said that, my vocal cords cause me to talk right now, there would be 20 articles written tomorrow about how I can't make that assertion with certainty. So I'm not going to say causation, but extremely, extremely rigorous analysis done with mental health. Folks that are predisposed to mental health or not mental illness or not predisposed to mental illness. Folks, when you control for genetic factors and you do studies on twins where half the twin smokes marijuana, the other half doesn't, genetically identical, lifestyle identical other than the marijuana use, you still see this increase among those users of especially schizophrenia, bipolar, multi-personality disorder, psychosis, and to a lesser extent, but importantly, still depression and anxiety. And when I talk to treatment providers around the country, this is exactly what they're reporting, especially among kids. In fact, they're not only reporting this, they report that, of course, kids deny that they have a problem in the first place. And we all know that denial is the hallmark of addiction, right, of all addictions. But with marijuana, it's especially pernicious. Why? Because it is much more easy to deny an addiction when you don't have, a needle sticking out of your arm, and you don't have that physical withdrawal that you get with heroin or cocaine. You don't have the heart arrhythmia and heart attacks as you have with cocaine. Those are these acute consequences that we see, and they're very easy to see. So folks are more apt to admit they have a problem with those substances. But when you talk about marijuana, because it's totally different in terms of those consequences, it's very, very, very difficult for treatment providers to get their patients to admit that. Again, sorry for the red, but it goes without saying in terms of the irritant to the lungs, bronchitis, cough, phlegm production. We know, actually, according to the American Lung Association, that marijuana contains 50 to 70% more carcinogenic compounds than tobacco smoke. So you would think, well, that must mean that there's a much more likelihood of cancer. Actually, the studies on cancer are mixed. Folks are still trying to figure out what the issue is there. Obviously they were mixed for tobacco in the 1940s, and then we learned that they weren't mixed. Right now, we cannot say definitively that marijuana causes cancer or is even correlated with it, but we're in terms of lung cancer, but that is a link that people are still looking at. The link to learning outcomes is probably one of the most important, I think, for young people, especially when we think about a competitive workplace, when we think about America's place in the world. I think it's also important. Folks don't usually make that connection. But what happened was the third largest city in New Zealand essentially runs the most rigorous study on human behavior in the world. This is a study that recruited everybody born in the years 1971 and 1972. Okay? So if you were living in Dunedin, New Zealand, the third largest city, and you were born in 71 or 72, you are enrolled into this lifelong analysis and study on your life. And they look at all sorts of things. So they check in with these people basically every 5 to 8 years, and then report on the findings on a number of issues. Well, one thing stood out for the researchers that were really, really shocking to them. They basically found, in a nutshell, that if you were a heavy, persistent marijuana smoker as a young person, in other words, they define that as really 3 to 4 years of regular marijuana smoking, that's about at least three times a week, you had an average of 6 to 8 points fewer IQ than those who looked like you exactly in other ways, in terms of your income, the way you were brought up, your education, your alcohol use, your other drug use, your predisposition to mental illness, all of these things, your occupation. They controlled for every single one of them. And they found that those who smoked regularly were 6 to 8 points on average fewer IQ. Now, that doesn't sound like that much. I mean, when I heard that, I was like, well, I guess 6 to 8 points. I mean, what is that? Well, you actually look at the IQ scale, which isn't used as much anymore, but when you go look at it, you find that 8 points is enough to take you from the top third to the bottom third, global average of intelligence.